All right, so the first thing I want to say is when I started looking into this, the ECMO growth and all that, the first thing I did is I used Google, as everybody would do. And what was interesting is the first Google search that you do, if you put in ECMO coverage in Google, you're going to find the first couple of pages is going to be all services that are set up to provide you that if you need it. So there's a business out there, and there's certainly a need, and that was what jumped out to me first of all. But along the way, I found a couple of interesting articles that I'm going to highlight in my talk, and there's two of them. But the first one is going to be about the financial differences that can happen when you move from ECMO coverage being 24 hours a day being the perfusionist, and then moving that to an ECMO specialist. And then the second one will be more about the logistics of what happens when how do you do this? I mean, what's involved and what are the issues with making this sort of a transition? Because I don't think people are ready to just jump right on and do that. So first thing I wanted to say is I looked into ELSO, of course, and what is an ECMO specialist? So I was a little bit weirded out by what an ECMO specialist is, by what ELSO says, and they say that an ECMO specialist is, it can be a nurse, it can be a respiratory therapist, it can be a medical doctor, and an ECMO specialist could also be other medical personnel such as biomedical engineers or technicians who receive specific ECMO training and have been approved by the medical director. So it's pretty much anybody can be an ECMO specialist as long as they've received this training by ELSO. So I think that's spooky to me because I think that as a perfusionist, we have a certain nature to understand things that we're just involved with as far as pressures, and we're used to the profession. Giving that to a biomedical engineer, I think, would be difficult. But this is the standards that are out there, and if we're going to reduce the costs, and if we're going to attack this growing need, this is something we're going to have to embrace. So I think there's conversation we could have about that. Do you advance the slides, Roger, or do I?
Do here.
Oh, I
you
do.
do.
Okay.
Right there. Yeah. The left and right. Left and right.
Oh, okay. Okay, so speaking about the costs, Jefferson University did a paper which was in 2010, and a lot of other papers quote this because it really showed a huge cost reduction in the ECMO coverage, and these were contract perfusionists that were covering the ECMO. They broke their study into a 2-year period of time. And the first year, what they did is they just tracked what was going on with their ECMO coverage. The total coverage was 2 years, and they had 74 patients over the 2-year period. The first year they had I can't remember exactly how many they had, but they had about 24 patients in the first year. And the cost of the 24-hour coverage by the perfusionist was $600,000. And their mortality rate was 42%, which is a little bit lower than what we saw earlier with Joe's numbers, but not bad. These were all adult. If they had any pediatric cases, they threw those out of the study. The second year, they had transitioned into using ECMO specialists, and they had a cost of only $234,000. So they really decreased their coverage costs, but they did increase their mortality rate as far as what I saw first off in the article when I read it. And they had a 61% decrease in costs, and then a 17% increase in their mortality.
That's not good.
That's not great.
That's not good. But there's, I have a feeling you're going to give us an explanation for that.
Well, the reason I wrote the slide that way was to talk about that.
Otherwise, you better tell us that they abandoned this project.
So, well, it always comes down to, I mean, do you if you can correlate that there's an increased mortality with perfusion being removed from the management of the circuit, but the cost is huge, but we're going to continue to have this increased number of patients on ECMO. How do we deal with that? Who makes that decision? And it really isn't us that makes that decision, but it's something we should look at. But there is a little bit more to the story. Mm-hmm. So just so we can cover the basis of what the article continues to describe is that the N on the first year, which was the year that they had the perfusionist covering, the ECMO was 12, and then the mortality rate the next year, the N was 27, and the p-value was 0.233. I'm sorry, 233. But if you read the article and you really look at the details of what kinds of patients they were covering between year one and year two, on the second year, the first year, very few of their, percentage-wise, very few of their patients were actually high-risk patients. So most of them were other kinds of patients, a lot of venous ECMO patients. But what the big change was between the first year and the second year, and what really affected their mortality rate was the risk that the patients, the mortality risk of the patients that they were covering. So on the first year, they had, I believe it's hard to see, but 20 patients.
See, you need glasses too. Yeah,
I know, I do.
You actually recommended I read this paper, which I did. And I saw the same thing you did at first was, oh my God, this 17% increase in mortality. This is horrible. We can't allow this to happen. But delving deeper into the study, basically they had their increase in number from the total, from the what was the original 12 and then the 24?
12 and 24, that's right.
Right. Almost all of that increase from year one to year two were patients in cardiogenic shock.
Right.
So
and that's a higher risk patient.
Different animal, right. And I think that's why that number was what it was, but it was also not statistically significant. So, you sort of have to accept that. So they haven't abandoned this program, I take it.
No, they're going forward because their cost saving was really significant. Yeah. And there were no actual citations of incompetence of the person who was running the ECMO machine. Their changes in mortality were really related to the kinds of patients that they were treating during that second year, which was higher. They had more people who were in cardiogenic shock who had a higher mortality.
Right. Now, and hope you don't mind if I just sort of throw these things out, but there were no citations of it. Now, there may not have been any pump disasters, ECMO circuit disasters, where a perfusionist not being there, they weren't able to manage it. So that wasn't the cause of any of these deaths that they said or mentioned. However, I don't know that I can say just because they had higher acuity patients that somehow would have no impact if it was a biomedical engineer with zero clinical experience. I mean, you have 20 years, you have 10 years, you have 15, 17 years. I'll just go ahead and say it, 39 years. I've seen we've all seen a lot of stuff. It's what we do every day. I don't know that you can translate that into an ECMO specialist, the years of experience we have in the operating room with everything that we deal with. So, I don't know. I don't know that I can 100% agree.
Well, I would excuse me, I'd have to agree with you as well. Basically, because how would you document that? At the end of the day, it's not going to be documented that the ECMO specialist wasn't paying attention or the ECMO specialist didn't do something.
Or maybe just didn't feel or really appreciate the nuance of maybe something that was going on,
Absolutely.
The dual circulation phenomenon or whatever.
But there's multiple factors that would play into this that, from what the article says, it doesn't show. I mean, again, anybody can be intelligent enough to run these devices, but again, our profession is the one that is solely what you do. You translate that from the operating room to now to the bedside. Again, nurses, respiratory, physicians even, do they learn about this? Yes, but that is not their main focus. And so something that I may see, if all I know is ECMO and heart-lung bypass, that I would feel that I would catch something before somebody else. Mm-hmm. I'm not saying that I'm better or worse than anybody else, but I feel that the perfusionist should be there. And again, I don't know how they would translate if a respiratory therapist didn't catch something.
Right. didn't see something that could have been addressed much sooner? And I think that is a very real question. We can talk more about that. I didn't mean to interrupt you.
That's okay. No, that's great. So what happened in this? The way they did handle that is they had a perfusionist available. Actually, 24 hours. For the first 24 hours, they had a patient. They had a perfusionist bedside, and then that perfusionist would step back. And this was the perfusionist did the cannulation. They would step back after that, and they would move towards just being available. They weren't in-house all the time, but they would be available to answer questions and also be within call distance to come in and handle a situation if it got to be something that.
And they did also call for circuit changes. So
they did the circuit changes. They did the initiation of the bypass. They did the circuit changes, and they did daily rounds. And they saved a lot of money. So I mean, that's. I think that's in the interest of the hospital. If we want ECMO to grow, and if we as perfusionists want to be a part of that, we can't come to them and say, well, we're going to cost you a lot of money, right? We've got to come to them and say.
But then, go ahead, Chris.
No, I was going to say, I don't look at it from a cost standpoint. Yes, I know you always have to crunch numbers for these things. That's how the world works. But I look at outcome. That's my first and foremost. I don't go in there, because essentially, even though we say, well, how much is that going to cost? We don't go in when somebody has CPR or the patient is down and we need to put them on emergent ECMO. We don't go to their face sheet first. That's not what I do. I've never done that. You don't. You go in there and you see that their saturations are in the 30s or they have no arrhythmia, and we're trying to get a pulse and we're trying to get access. Right. That's what we do. So that's how I look at these. And that's why I see the difference for perfusion at the bedside versus, say, respiratory. Look at it from this perspective. When you have such a device that is required, you need somebody to run that for that. I mean, why not cross-train and have us run the ventilator? Same concept. That is such a specific device that you have a technician, clinician that runs the ventilator. Right. Physicians know about it, nurses know about it, but at the same time, you leave it up to that person.
And if you're in a hurry to set these things up, the patient really is coding. They're doing active CPR on these patients. Correct. They're trying to shove cannulas in there. I mean, I'm a perfusionist, and I have almost forgotten, has anybody given the heparin?
Correct.
So it's a madhouse in there, and it's just that kind of experience that can make a significant difference. Sorry again.
No apologies. That was the first study that I looked at. The next study that I have involves more of these. And by the way, this first group was. The Jefferson study involved contract perfusionists, and they made, I think I can go back a couple slides here and show you their financials. There we go. So the first year, they ended up billing $600,000 for their services, and that involved setting up the ECMO circuit, 24-hour coverage, and then also just everything that was involved with the ECMO. There was nobody else involved, just the perfusionist, which is what we do as a business, and it can be taxing on the perfusion.
It's service. Horribly taxing on the staff. It's stressful. Yeah. Especially when you have multiple ECMOs in multiple hospitals. But I will say this, and I think that for anybody that may be watching out there, I want to make this point. You see that number of 600,000. That doesn't mean that the company that is providing the clinicians to that hospital made $600,000, because that is going to pay salaries of people to be there in the room to do this. So
and supplies.
What you're saying is the nurse at the bedside or some other person, ECMO specialist hired by the hospital, is going to be in the room, or maybe even hired by the contract company. That could happen too, the contract service. And it's just that's the cost to the hospital. That's not necessarily the profit to the ECMO service, because you don't work for free.
No.
I don't work for free.
I certainly don't.
You certainly don't. And, you're the only one who's ever volunteered for that.
All right. Can we cut that part? All right. So But yeah, so that was the billing. This was a study of the billing. It wasn't a study of they don't know what the contract company made from
Right.
You know,
Well, I'm
as
just
far
telling
as
you,
profit,
as
but yes, that
I'm
was
just
the
telling
bill.
you, as a person who owns a service that
Yeah.
provides this kind of thing, people look at these numbers and go, "Oh my God, look at how those people are making
Yeah.
just ridiculous amount of money." But
And-
that's maybe for perfusion is salary.
Yeah.
And if you
Yeah.
have a 24/7 coverage, that means you're going to have a minimum of needing 3 perfusionists to do that. You could do it with 12 if they just don't ever want a day off and they just want to do 12-hour shifts for however long they have to until the ECMO is completed. But this sounds like a busy ECMO program. So you have to have a bare minimum of 3.
Right.
So
And
there's really from a company perspective, it is a lot less financially rewarding than people would imagine. But it is such a critical service to provide that to not provide it would mean you would not have a business at all for doing the hearts and everything else. And let me just add to this if I can. I've gone through this in some of the discussions that I've had with large university type hospitals like this, where I'm trying to negotiate some kind of an agreement. And one of the things I hear all the time is that your competitors only want the meat off the bone. They don't want any of this other gristle that's over here with this ECMO stuff. They want to come in and do all the hearts, and they don't want to mess with the ECMO at all. Or if they are going to do it, they're asking for a retainer, which makes it cost prohibitive. And these hospitals are taking a big step back and saying, we simply cannot afford it. You can't keep providing the service. We are clinicians first. I mean, and I think that is different. We're all not administrators here at this table. I mean, I'm a clinician first. Been practicing perfusionist for 39, I'm in my 39th year. So that is my passion, is patient care, making sure that I'm doing the right thing for the most vulnerable amongst us in that circumstance that they're in. But I also recognize that if the organization, whether it be the hospital or my company, is not financially sound, then it doesn't work. It folds, it falls apart, and the service that you're providing becomes very substandard. Mm-hmm. So I do think we have to be sensitive to this issue of finances. It's how can we provide the highest quality of service for the most economical price, the best value for the best price. And that is the never-ending struggle every organization has, whether it be a hospital or whether it be a service like mine.
Mm-hmm. It is interesting that you would mention retainer, because the way this contract perfusion company structured, I imagine that the hospital came to them and said, "Look, we want to do more ECMO, but we can't pay this price. It's too expensive." And remember, on this study, on year 1, we had 24 patients. On year 2, we had 48, so almost double.
Right.
Whoops, lost my.
Right, and we don't know how long they were on ECMO. Were they
Right.
month long?
Well, the average was 5 days.
5 days.
Yeah.
Well, okay.
So that was
they
the
had
average.
some that went in and came out right away, and then others that might have lasted.
You know, one thing it's not mentioning here, though, there's a few things. Really, everything's a matter of perspective, especially from a hospital standpoint. While I'm not an administrator, you're looking at it when you first read it and you say, man, that costs $600,000. There's no mention of what their reimbursement was. Mm-hmm. To say, yes, it cost $600,000, but the hospital's revenue was $1.5 million. So now they only had, $700,000-$800,000 profit they made.
Well, that's not necessarily profit, because they still have to have the lights on. They still have to have the nurse at the bedside.
Correct.
They still have to have
But from
therapist
an ECMO
and
standpoint,
intensivist. Right.
all I'm saying is, yeah, it costs $600,000, but you have perfusion around the clock. You didn't lose money. And I'm not saying they did or didn't, but because it doesn't mention it, it's just out there. Mm-hmm. You didn't lose money, but now you've offered the most extensive help benefit to a patient that's known right now, technology. I mean, you are keeping somebody alive beyond what their organs are saying to do for $600,000 42% of that patient population is still alive.
Yeah, with very good, well, even sometimes more than that. I mean, 40 to 60%, depending on.
Well, I'm just going
the
according to their
circumstances.
article. It all depends on
Yeah.
their program. But now, having said that, now you're saying, well, if we use somebody to wash the machine for you, yeah, we may lose a few more people, but man, you cut your cost by this much. So now it's really what is important to you. But one thing also they didn't do, and they're just monitoring this program, is what I foresee happening and going along with what you were saying and what you were saying is, I don't know necessarily that they're going to be doing this on the street corner, but my next guess would be that you're going to train ER physicians to look for it and know when it's going to be viable. And they may have one circuit in the hospital, and they're going to have programs that they're sister programs that they're going to say, hey, John, we got an ECMO patient. Great. They're going to put them on ECMO. Then the major center is going to come pick them up, fly them up, and offer the best of the abilities, because that's one thing that they're known for doing. And so now your community hospital saved the life, used the service, and is not taking the big hit on it. That's what I foresee the future as.
Yeah, as long as they keep them a certain amount of time because of the reimbursement structure of CMS and all that stuff. That's
I don't
very,
see anybody on
very
ECMO.
confusing.
Yeah, I don't see anybody on ECMO for a few days, and 7 days later they're home.
Right,
It's usually a
Right.
lengthy stay, whether they're on or off.
right.
But I do foresee that's the way it's going.
I think you're probably right, but I'm going to be real provocative here, just for the sake of being provocative. I don't do it often, but I want to do it just for this one time. I've also seen where there's some nurses who I think are way better at managing an ECMO than some perfusionists.
Correct.
Not as a rule, but I have certainly seen those exceptions.
Correct.
Especially in places where a person's been there for the past 15, 20 years, never did an ECMO, gets an ECMO patient. And the next thing you know, they have them on ECMO with the heart-lung machine in the ICU with a reservoir on top of
Yeah.
it. And they're trying to roll the patient to CT, and the pump has to go downhill, and they're
Really?
they're draining the IO. I've seen that happen several times. It's very frightening. So I think we need to do a better job at helping our colleagues be part of this conversation and all of us, sort of collaborating. I don't think we do such a great job with that, but that's another topic for another day. I think it's something we need to do better. And you have somebody here with us, right? And
Yeah, that's for our next paper.
Introduced our guest that's going to be on spot. Okay, well,
Sure,
I'm
but let
gonna
me
ask
just
you to
mention,
do
I
that.
wanted to point out how this contract perfusion company structured this transition, because on both of the papers that I am presenting, it's about a transition from having perfusionist 24-hour coverage to ECMO specialists, and one is from a contract company and one is from in-house perfusionists. So this particular contract company, the way they structured it is they said, okay, you want to reduce your costs. What we'll do is we will charge you a retainer of $234,000 per year. And for that retainer, what we'll do is we will train people in your hospital to be ECMO specialists, and we'll do that yearly. And we'll put the ECMOs in, and we'll provide 8 to 12 hours of ECMO coverage for the first part of it to get them stabilized. And then they'll back off and they'll come by once a day. And that was their charge. So I'm thinking from being somebody who's been a contractor and working for a contract company, if you could go to a hospital and say, rather than the expenses that you're incurring, we'll charge you this retainer, and we'll do as you could grow your ECMO program as big as you want. We'll handle it for this same capitated price. They'd say yes.
Well, I will tell you
Would
this.
you agree?
Well, I don't know. Maybe, perhaps. I mean, some hospitals, I've heard some hospitals tell me, well, we cannot have our nurses running this because we would then have to change their job description, and that is an extremely complex thing to do.
Yeah.
But then you get into this argument of, well, how come in certain cities at hospitals, all of the pediatric cases are run by nurse ECMO specialists, but the adults can only be run by perfusionists. I mean, I know children aren't little adults, but they're just as. It's like, I don't get it. There's too much contradiction. And when you get that kind of contradiction, I think that it opens the proverbial Pandora's box where people just decide, you know, you don't really know, you don't have a handle on this, and we're just going to have to figure it out ourselves. And they usually don't figure it out that well, but they don't recognize you as a real expert on this because you're talking out of both sides of your mouth. So the kids can be run by nurse specialists, but adults have to only be run by perfusionists. And that doesn't make sense to most people, including me.
Well, that's where ELSO comes in. So they have a certification program, which some hospitals are accepting, and people can go and get certified, and some of the hospitals are saying these are the people that can operate the ECMO circuit, which I was spooked out about as well. I mean, that's why I showed that first slide.
I'll tell you this, if we don't fix it, if we don't figure out what to do, somebody else is going to fix it,
absolutely.
and it's not going to be to our advantage.
Yeah, we need to be in front of it.
We saw heart surgeons do this with catheter skills, with wire skills. They lost all of that to cardiologists. Cardiologists have become the all-powerful in the hospital, the gatekeepers to what happens to the patient that comes in with ACS, acute coronary syndrome. And we're going to do the same thing.
Correct.
Let's move on to the next paper that I'm covering. And I have a special guest. Her name is Suzanne Osborne. She's a friend of mine. And at the time that this paper was written, she's Skyping in. At the time that this paper was written, she was the chief of perfusion at Emory University Hospital. And so while she's not listed as an author of the paper, I know that she was very involved with what was going on there as they transitioned as hospital-employed perfusionists to backing off from covering the ECMO. And so she has a lot of insight. Are you on? Can you hear us?
Yeah.
Oh,
Yeah.
great. Okay. Good to see you.
Could you ask her to lower her camera just a little bit so we can, because your chin is cut off. Oh, she can hear me.
Oh, perfect.
Oh, that's much better.
There's the
Hey,
full Suzanne.
There's the whole person.
We had
Yes,
Suzanne from
yes.
up.
We have the whole
Yes.
person now.
the whole thing.
Okay, good.
So in the paper that I read that was published from your hospital about this transition, a couple of things jumped out to me, and I was thinking that maybe you could talk about some of the points. The first one is they really emphasize the importance of institutional commitment to the transition and the coverage. Can you talk about how that was and how the institution was involved with this transition?
So before we started the transition, we didn't have a ECMO physician. Our chief of anesthesiology decided to recruit someone from the University of Michigan, an attending co-care physician from U of M to come down. So we actually had meetings prior to him actually joining the physical team, but it was a complete interdisciplinary team from nephrology to pulmonology to cardiac anesthesia to regular anesthesia to the CEO, the nurse educator of the unit, of course, and the respiratory therapist director. So it also helped that our actual CEO was a prior RT, so that kind of helped the whole thought process go along a little bit smoother than it would normally.
So
go ahead.
well, what about the physician leader? What was their particular role and how they were involved with the transition and the ECMO management?
So we actually physically had to write policies and procedures and protocols from the start because we were doing basically ECMO ad hoc prior to this physician coming down. So we had to do all that from the beginning. Now a lot of them are mirrored off of ELSO and U of M's policies and procedures and guidelines. So that helped. That helped with that process.
And you did the did the training for the perfusionist. I mean, for the ECMO specialist, or did your group?
No, so we are or were a remote cannulation center. So what happens is the perfusionists go out and physically get the patients, either by air or by ambulance. And Emory is a for cardiac hospital, but other hospitals growing, and one of the largest centers in the Southeast. So. So yeah, the perfusionists actually were the individuals that flew and get the patients. But in the training, we actually sat with the RTs, because it's an RT-driven program, kind of mirrored off of U of M's program. We sat with the RTs for 2 12-hour shifts, and then gave them an actual competency test, both hands-on and physically written. And this was after because we used the cardio help, this was after their 5-hour comprehensive cardio help training, along with I think it's 2-day training. It was originally with an individual from Eggleston across the street, but since then now he's the chief of perfusion there, and now teaches that course.
So what was the biggest? You had institutional buy-in for sure, because they wanted to reduce the perfusionist time commitment, and I know that also it mentioned in the surgery that there were actually delays in surgery because you had perfusionists, they couldn't go and operate the heart-lung machine because they were held up doing ECMOs.
Correct.
So you had the institutional buy-in probably for that reason, and then also. You did the training of the respiratory therapists, the perfusionist
Correct.
did that, and you had a kind of a sign-off sheet. Was there something else, Joe, that you were going to mention?
No, I had a question on the YouTube chat, but I don't.
Oh,
wanna
go ahead,
interrupt
go
your
for
thought.
it. Go for it. Let's take the question. That'd be good.
Okay. So let me ask you that. Can I see that sheet?
Sure. You may not be. It's very small.
That's okay. So now, Suzanne, are you still at Emory?
No,
No. Okay.
I am not.
Okay. So the question, let me ask this first question from John Ingram, and John is a perfusionist, and he is asking that we spend years obtaining our CCP, our Certified Clinical Perfusionist, and months obtaining a state license in those states that have individual state licensure, only
Right.
to arrive at an ECMO coverage job to find that ECMO specialist is managing the patients, and they have neither. And I have to say, Suzanne, and I definitely understand the paradigm, but what you described as the training, though I am confident you and your team, while you were there at Emory, probably put a tremendous amount of work into training RTs to do this. I mean, they have zero hemodynamic monitoring skills. They have zero understanding of, of fluid compartment
management,
shifts and acid. Well, they might understand acid-base balance,
Yeah.
but electrolytes and lactate and hypoperfusion syndrome and they get a 2-day course and they're an ECMO specialist. That seems
No.
that
Emory
doesn't
is
seem right.
Emory is a teaching institution. It's critical care medicine, 24 hours a day, including EICU, which is monitored with a camera and remotely monitored with nurses and physicians, critical care physicians. Our ECMO director could probably run to the hospital quicker than parking at the hospital. He was that close. We were on call and could be called at any time. And knowing that Emory is a heart, lung, and VAD center, we were in house probably out of 24 hours a day, probably 20 hours of the day.
Yeah, and Suzanne, I hope I didn't come across poorly. I definitely am not trying to put you on the defensive of justifying this. I'm really just trying to wrap myself around. I just don't think, I just simply do not feel regardless of all of those other variable accoutrements that you just described, that it is adequate for someone, given the amount of training that we all do, including yourself, that they can run an extracorporeal blood circuit that has a artificial heart, an artificial lung, a heater, a heater cooler element to it, or a, what am I trying to say?
Well, I have a question.
exchanger.
Here's my question.
And,
Since
and
somebody
2 days, they're qualified. I think that baffles my mind. A nurse, I can kind of understand it. A nurse, I sort of can, because they understand all of these things that happen. These are complex patients with anticoagulation. How much anticoagulation training does a respiratory therapist get in the respiratory therapy training? I don't think any. And again, I'm not meaning to seem overly passionate. I'm just shocked.
I don't disagree with you, but I also think this is a conversation that probably should have occurred 40 years ago or 30 years ago when everything started up here at the University of Michigan.
Yeah, well, 30 years ago. But 30 years ago, 40 years ago, definitely the mortality rate was 99.99999. The only one that survived was the one that they couldn't get the ECMO in.
Yeah.
I mean, so
there's a lot of things wrong with the University of Michigan, but
the other side of it, there has been, numerous things that perfusionists have given up.
Well, that's true. I can't argue that. You're right. You're right about that.
And we're in this world today that we have personnel problems.
Yes, although we don't have enough of us. So we're confronted with a big problem. I agree with you.
I have a question, Suzanne. How often, do you know how often somebody as a perfusionist was called in, if there was somebody in-house to give help, or was it pretty easy for those respiratory therapists to just take this over?
The director of respiratory therapist put stipulations out of how many people on his team were going to be trained initially. So only the individuals that had X amount of experience and wanted it, and had the had a bachelor's degree also. So I felt like they grasped it very well. Most of them were, during their training, were asking very appropriate, very good questions. They're used to the ventilator. They're used to lungs. They're used to that type of thought process. Yes, you had to teach them a little bit of heparin knowledge, anticoagulation knowledge, hemodynamic knowledge. But again, it's about a team. And they were the individuals that were physically sitting, in front of the pump. But they had a team of very knowledgeable individuals around them, either in, the unit or by phone. And to answer your question, Patrick, I had to troubleshoot over the phone a situation, and I was able to do it. But I would say out of 2014, I think, is when this paper was written. Out of the 3 years I was there was maybe a half a dozen times that we were either called in or called in the middle of the night. Mm-hmm. Now, mind you, we rounded before we left. We were in the hospital a lot of the times, and if something needed changed out, we were there. But again, that was, I would say, 95% of the time during normal working hours.
So the paper doesn't really mention mortality rate, and that kind of came up in our last paper. Are you aware of any changes? Did you, because it wasn't part of the paper, just from your feeling, do you think that it was worse or not after this transition happened?
No, we were doing it very ad hoc, and this paper was written after we had stipulations on the patients we would take. Mm-hmm. Now, mind you, the thought process was also because we had an established program, we would go out and get some of the patients that probably might not do well at a center that didn't have an established program. So we felt, the borderline patients that we might not take because of, their issues, we would take those from an outside center because they had a better chance of survival at our place that had policies, procedures, and guidelines on how we did stuff.
Sure.
So,
I would agree with that.
Okay.
Agreed.
Yeah, I think that makes sense too. Of course, then that's a whole nother topic, in
Right.
terms of centralization versus not. Should these other hospitals only insert, stabilize, and then ship them? Should they keep them and take care of them? You've got control issues and ownership issues and logistical issues and all of those other things that go along with that. So, it's a So if I can ask that same question Patrick did, only I want to ask it in a different way. With it all being said, did you feel that the patients were receiving the same level of care with the ECMO specialists, respiratory therapists versus the perfusionist, or did you see any difference in the quality of care given to the patients from an ECMO management perspective if it was a respiratory therapist ECMO specialist versus a nurse ECMO specialist?
It was never a nurse ECMO.
Oh,
it
it never was in
it
this
went from
study?
perfusion to, unless I'm wrong,
So
it went from perfusion to respiratory therapist.
So up till I want to say about it was probably about a year ago. Because of staffing issues, they decided to allow some nurses to be trained also.
Okay, so it is happening. Okay, so
Okay.
I think that's.
Well, that was a good
I'm
insight.
personally, I'm just more comfortable. I
Wasn't
love
initial.
respiratory therapists. I'm just happen to be
Right.
more comfortable with nursing that have ICU experience. I just think they understand. That's just my opinion. Doesn't mean that I'm right, but intuitively it seems like it makes sense to me. But anyway, okay. Do we want to?
Well,
did you
I have
more?
one. There was one thing that was sort of nebulous in the paper, and I don't know if you know anything about this, but they said that one of the keys to success was having an outside consultant service evaluate the ECMO candidates. Who was that? I mean, don't tell me who it was, but what is that?
No, tell us who it was.
It doesn't say.
Well, what
That's
you
what
can
it
tell
says.
us.
Right.
Could you tell us
Yeah.
who that is?
Well, don't
Well,
tell her
no, we
not to
just said,
tell us.
just the call would come in to a transfer center.
Uh-huh.
And the transfer center had, basically a nurse, and they would ask all the questions. And then from there, it would go to a assistant administrator if we had to get a plane and or ambulance, and the critical care physician on call.
So there was not some outside consulting service that would say, this is a good perfusion candidate, I mean, this is a good ECMO candidate or not. I thought that was interesting in the paper.
Internal process.
Okay.
I mean, the transfer center is really not employed by Emory Healthcare, but yeah.
Hey, we're probably going to open it up for calls later.
We are.
And if we do, can you stay on for a little bit in case somebody has a question for you?
Sure.
Yeah, we're just gonna. Yeah, hold on. I'm getting yelled at that we're running over. But yeah. Oh yeah. Don't forget to mute your mic.
I'll do that.
Well, when we go on commercial.
Well,
'Cause
I
if
wish-
you don't, then whatever you're doing back there, everyone will hear. And we've already had that experience.
Yeah,
with
I wish
Rodell.
someone would let me know
Yeah,
that.
exactly. So.
So there you go, Suzanne.
Yes.
There's your warning.
So you don't mind hanging around a little bit because we can. I think we still have Rodell's talk to give. So why don't we do this? Why don't we take a short commercial break? I've got one other point though before we go, and I'm really sorry, but I don't want to miss this. John Ingram again asked that. Charlie Reed often asked this question 30 years ago as discussions about giving away ECMO first emerged. The shortage has always driven this, but perfusionists should take heed. I think that's very sage advice right there. And he also adds that the final comment is everything is going along fine with a non-perfusionist until it goes wrong. And I think that's another very good point. It all seems easy when it's all just running and going in circles. But when it really does fall apart, look, I've been on cases before where the femoral arterial cannula has come out. And that's pretty dramatic. And you really do have to react. The patient survived. But you still have to, if you have to react properly, and you have to be able to help whatever physician, surgeon, or whomever is reinserting that cannula to do it in a way that doesn't later cause even more harm.
Right, yeah.
It's and those things happen, and I know they're not common and that they're somewhat rare, but it's like anything in life, you only, all of us really only get very few opportunity to really show what we're made of. We get that case or that situation in life, it could be anything, where it's your time to act and you're either going to do it or you're not.
Correct.
And that's what ends up defining you